me about this case was, the questions about infection control. I think this is something that kind of comes up every once in a while. I mean, because we often hear about these BCG cases initially, either before they're speciated as BCG or they're reported to us as part of due diligence of a lot of hospitals, which is really great. But then after that, we don't really do a lot with these cases. But this was something that I wanted to have a little bit of a discussion about. So, we learned that this patient did live in a nursing home, certainly in the few months before he was officially diagnosed. He had several hospital stays. So should a contact investigation be performed for this patient? Yes, no, only if the culture is positive from his respiratory specimen. So I'll let people vote about that. Okay. So I don't think there's consensus on this, which I'm not surprised about when we're talking about this. And again, there's not a whole lot of guidance about this. I think this was kind of, again, brought to the forefront of our mind last year when there was an MMWR that was reported of a case of possible, although I think pretty clearly, airborne person-to-person transmission of M. bovis in Nebraska. This was not related to BCG, but it really did raise the issue of the possibility of M. bovis transmission. And so I think that was actually really interesting. But then, let's learn about, from the folks that actually do this all the time. So in the Northeast, I think we would argue we don't see a lot of M. bovis cases. However, in California, especially Southern California, they actually do this all the time. So actually a lot of the studies are from San Diego, when Phil Abu was there. And so this is a retrospective review of MTB cases and M. bovis cases for which they did contact investigations in the 90s. And it included 15 M. bovis patients and 117 MTB patients with 77 contacts and 469 contacts, respectively. And basically, the upshot of this was that when they looked at the number of people that converted who were exposed to the M. bovis cases versus the M. tuberculosis cases, and they looked at these predictors that you would think would impact whether the source patient would have been more likely to transmit or not, they really didn't see any difference, which was interesting. So there was no difference if the person had a cavity, if they had a cough, or if they had HIV co-infection. And so what they had, the upshot of this, although they recognized some biases here, was that, certainly at least for M. bovis cases that are smear positive and pulmonary, you probably should treat them the same way as you would a smear positive MTB case when we're talking about a contact investigation. So I thought that was interesting. And then I figured I would actually look at what the CDC contact investigation guidelines say on this, and these are buried quite deep in the guidelines, which are also a little bit dated, as many of our guidelines are right now. But this is the one paragraph that does address M. bovis infection and kind of what to do in regards to contact investigations. And basically it says that, I'll just read the second sentence, contact investigations regarding persons who have pulmonary TB caused by M. bovis should be planned according to the guidelines provided in this report. And then right after that says, however, the potential for transmission is less clear. So I think that there is still some debate on this. I think there is data out there that shows that certainly for folks that have the same characteristics that we would be concerned about for Mycobacterium tuberculosis infectivity, those are folks that you probably want to treat similarly. When those characteristics are not there, I think it's certainly less clear. So in this situation, because the patient initially certainly was NAT negative, which we were very happy to see, but did end up being culture negative, we did not pursue a contact investigation in this particular situation. I think that given the place where the patient was living, we could have gone either way, really, but I'm certainly reassured that he didn't grow anything. I think that if he did, especially given that he was in a nursing home, I would have recommended a contact investigation in this situation. So I'm very happy to hear what other people have done in similar situations. Again, we get maybe 2 or 3 reports of this a year in terms of a disseminated BCG, and at a minimum, I usually ask my staff to recommend that there be at least a minimal contact investigation, especially when it's for pulmonary cases of like immediate family and things like that. But this one definitely, raised this issue very early on because of his immediate past history.
Thanks, Lynn. I have a few questions, but because I would agree that in this case, he probably would not have had to pursue a contact investigation, as there was no evidence that it was really involving the lung. Was there any procedure that potentially could have aerosolized? There was nothing, right? She didn't go.
Well, I mean, he had this VATS, so I don't know. I think Dr. Bolanowski could educate me more on exactly what that would have entailed. But otherwise, no, I don't think so.
So, Dr. B,
well,
VATS.
with a VATS, you just make a small incision, put the scope in, and look around.
Okay.
And the patient is intubated.
Right. Okay. So that would have been potentially an issue, right?
Any of the equipment used on the respirator is usually discarded.
Okay.
Tubing, any of the tubing, and naturally the ET tube itself.
Yeah. So with VATS, they have 3 incisions.
Two
or
or 3. It depends on what you're trying to do.
Uh-huh.
You are trying to do a wedge resection, you may even have 4 incisions.
Okay. Yeah, but generally it's a closed procedure.
Oh, that's
Right.
The surgical part is closed. The only danger is the intubation.
Yeah. But in this particular case, there's no evidence that he had it in the lung.
No.
Right.
Correct.
Right.
Right. Initially, it was unclear, so we did some, but clearly at this point, I think I'm pretty comfortable with that assessment, yeah.
Any comments, Mark? Have we ever had a situation where somebody developed disseminated BCG or BCG
We have had
pulmonary
at least one that I can recall several years ago. We did not initiate an investigation, and Lynn, in the email that I shared with you in October,
Yes.
At the time I had said if it's respiratory involvement, then we would initiate an investigation, but this is clearly not.
Yep.
Yeah. But we haven't really had more than 1 or 2, maybe 2, but we did initiate an investigation either.
They tend to be extrapulmonary.
Yeah.
Right? So either it's sepsis like Dr. Freyma's case was last year, or this one is quite unusual, Alina, that it actually did cause meningitis and you were actually able to isolate it from the CSF. So I think you should contribute to the literature as they seem to only have 1 documented case. So you should be the second one, right?
I plan to.
Yes, good.
Lynn and I will, I'm sure we'll work on it, right, Lynn?
Uh-huh.
Absolutely, yes.
You could include the consultant who helped you out. No, just kidding. So this is kind of my other question is, so he had his BCG treatment 2 years ago. Now, Lynn, looking at preparing for the discussion.
Yeah.
Generally, people who develop BCG disease develop it sooner than later.
Yeah. I mean, I forgot exactly what I saw, but certainly within 3 months, it seems to me more likely. So I did realize that the time, I don't know if Henry, you have anything to add here. It seemed like it was a long time for this to happen. But again, it's all in context because really he was sick for at least 6 months before he was diagnosed.
Right. It's been kind of brewing for a while.
Yeah.
Can this be reactivated? So my other thought was maybe he was bacteremic back in 2014 and then had a nidus and then developed a latent infection, and all of a sudden when he really declined, because of other comorbidities, he reactivated. But I'm not sure if BCG reactivates the same way as, latent TB would.
Well, hi, this is Henry. I think the presumption is it must, because there are reports of very late cases. Again, they kind of stratify out as to a lot of these cases that occur within the first 3 months of treatment during their actual courses, and then sort of these smattering of cases that seem to occur later on in time, and the presumption seems to be that those late cases represent reactivation. We had a guy that we just treated here that had it reactivate in bladder 5 years after his last BCG, local BCG treatment to the bladder, so it has, presumably it has to be reactivation at that point. So the presumption seems to be, at least from the literature, that some of these people do have a transient dissemination and then can be quiescent and then flare in other foci. I guess the one interesting thing about this case, and I'm sorry I missed the beginning of the presentation, this was a carotid aneurysm or a subclavian?
Subclavian to the origins of common carotids, yes.
Right, because then the question is, was his initial dissemination, his initial reactivation focus really the artery, and then the meningitis secondary to that? There's seems to be a lot more descriptions of aortitis in the literature in these disseminated cases. I think in the slide that Lynn showed, like about 5% of these cases seem to be aortitis presentations, as opposed to the really low number of meningitis cases. And I don't know what causes that predisposition. I know across the river at Penn, they just had an abdominal aortic aneurysm with BCG that was also a late case, like 2 years after. So you sort of wonder what the pathogenesis is and what the vascular propensity for BCG seems to be.
Right. So, you did mention in the beginning he did present with fevers and chills, but that's a fairly common reaction to this therapy, right? They generally develop some fever and cystitis-like reaction. Is that expected when they use BCG, Henry?
So low-grade fever, very common. Higher grade fever, maybe 5% have reported higher grade fevers, if I remember from some of those pooled analyses. So yeah, the finding of fever is not that uncommon. I think, and unless you remember anything different, Lynn.
No, I don't think so.
But his urologist was concerned enough to the point that he actually shortened his therapy because he continued to have chills with his therapy, with his installations.
Yeah. So that could be a sign that there was some systemic dissemination at that point.
Seems that way.
Yeah. So, go ahead, Jerry.
I wanted to ask a question about the predisposition. I missed Henry's presentation, but was there anything in the literature? I thought I remembered that if there's bleeding at the time of the installation, they're not supposed to instill after they catheterize the patient. If there's bleeding, they're supposed to wait. So did you see that as a predisposition?
Yeah, that's considered to be a contraindication to if they have hematuria or active bleeding at the time of the catheter insertion for when they do the installations, because that appears to increase the risk of some of these more severe reactions.
Right, it makes sense. The vessels may be open. Yeah.
There has to be a portal.
Right.
So you must have said this earlier. This was ID'd as M. bovis
That's correct.
and PZA resistant then.
It is PZA resistant, yes.
Okay. So you did kind of gloss over your management for this meningitis case, but just summarize again. You started with 5 drugs and how much steroids and how did you do it?
So I started on the usual rifampin, INH, PZA, and ethambutol. So because at that point we only know that that was MTB complex. I also added IV moxifloxacin. The reason for 5 drugs is because I wanted at least 2 of the drugs to be parenteral since patient wasn't really swallowing very well. So the rifampin was intravenous, moxifloxacin was intravenous, and I thought if he could get at least some of these drugs in by mouth, then at least he'll get good enough levels. And then the dexamethasone was a 0.3 mg per kilo with tapering doses over 6 weeks. And eventually we transitioned him to oral prednisone. We had issues with like a mild adrenal insufficiency with him, so he remained on hydrocortisone. But the initial starting point was 0.3 mg per kilo.
Okay. And then when you got the ID and sensitivities, you just dropped the PZA and continued with the 4 drugs?
I dropped the PZA. The problem was that he also dropped his platelets to 50,000.
Okay.
So I was holding up until the last moment not to change any of his other meds other than PZA. But once he dropped to 50, I had to do something. So I stopped the INH and ethambutol, and started him on ethianamide. So on the 3-drug therapy, ethianamide, rifampin, and moxifloxacin, his platelets rebounded back to normal. But then he had issue with the ethianamide, developing nausea and vomiting, and developed aspiration pneumonia. So then I got rid of the ethianamide and put him back on INH. And actually, as of yesterday, his platelets dropped again to 60,000. So whatever the plan is today in terms of his care, I will have to adjust it again.
Also, he's had about 2 months of therapy now?
No, he's still on therapy. It's just because there is complexities in relationship between different children of his. Some of them wanted him in hospice regardless of this diagnosis. Then they changed their mind, but now he's really declining because of CHF, malnutrition, difficulty handling secretion. So I'm going to try my best to see if I could still, involve the family in the decision, but continue to treat this patient. But he may be coming to a point where he's going to be transitioned to hospice.
That's unfortunate.
But if that does happen, I have a very good relationship with all the family members, and I'm hoping that we will get an autopsy then.
Okay. Yeah. Any other comments or questions? Lynn, what would you suggest would be his maintenance treatment then? Rifampin and moxifloxacin seems reasonable. Ethambutol.
Yeah, you tell me. I mean, luckily it's not TB, but obviously we don't want it to get worse.
Yeah, I think
so. Yeah, I mean, as many drugs as we could keep on.
Mhm. Yeah. Yeah, I think that you seem to have shown some response, so we're at the point of just deciding something that's reasonably tolerated, that he could carry on and not make that the cause of his demise.
Sure. Yeah. Yep.
So,
yeah, because I think any of the other second lines also have platelet issues, or so it just gets a little tricky.
Yeah. There is a question on the chat box asking whether you thought the altered mental status was contributing to some adherence issues. Perhaps it wasn't much of an issue because he was actually always supervised in some kind of skilled facility, right?
He was supervised, but early on he was refusing to take medications.
Oh,
and
okay.
he was very abrupt, and the staff did not know that this is not his baseline. But within several weeks, he was a different person. He was very pleasant, smiling, hungry, taking all his medications. So yes, definitely, if things went as well as we hoped and he went home, compliance would not be my concern.
Yeah. All right. So this has been a really interesting discussion. Any other questions from the folks on the line? You know, I really enjoy these. Yeah, go ahead, Jerry.
It's not a question, but it's a comment. I've been thinking maybe bovis is harder to treat in extrapulmonary sites than we thought. I'm not sure, because I think it was at least 10 years ago I had a case of a woman who prepared the bladder installation but stuck herself in the hand with the needle that she had drawn up the BCG with, and she got a horrendous hand infection that was very hard to eradicate and eventually needed plastic surgery for reconstruction.
Yeah. Yeah. I don't know if it's the organism or the strain itself versus just it's hard when you get these skin and soft tissue infections with mycobacteria. They do require a lot of management, repeated debridements and all that. So, but fortunately, these are uncommon.
Right.
Yeah. Again, I think we're up to 1 o'clock now. I really am enjoying these lunchtime talks. What better way to spend a Friday noontime, right? And we've been getting good participation from across the region, and thank you for calling in. And really, if you think it's an interesting topic, please feel free to share it with your colleagues. Thanks, Alina and Lynn. As usual, Lynn, thank you for sharing your cases with us. And I'm sure everyone who's been on the line the last 2 weeks have really gotten more enlightened with the perils of BCG therapy. Thanks, Henry, for calling in and contributing to the discussion. The next Grand Rounds is scheduled for December 9th. And here we go a little more, I think, basic science this time. And we'll look into household TB transmission and biomarkers for disease progression. And Dr. Salgami, who's an immunologist, TB immunology researcher here at Rutgers, will be discussing that Grand Round. So hope to have all of you back on December 9th. And in the meantime, everyone have a good Thanksgiving. Thanks, everyone.
Thank you.
Thanks for the case. Thank you. That was great.